Разрешите открытие нашего пленарного заседания, официальное открытие съезда. И слово для приветствия представляется одному из наших старейших членов нашего общества, Юрий Иванович. Пожалуйста, Юрий Иванович.
Дорогие друзья и коллеги, не знаю, как ходите от наших сессий. Сегодня 60 лет мы запустили первый мультизм. Теперь слышно? Я узнал об этом сегодня, когда ехал. нашлась наша специальность. В начале 40-х годов вот эти трое специалистов, Андре Курнат, Берн и Ричардс, начали целенаправленную категоризацию сердца. С этого началась наша специальность. У нас в стране, в Советском Союзе, России, это началось все после войны, и начали ее бывшие армейские хирурги. Если открыватели, начальники были физиологи, то у нас в России это были хирурги. Будьте любезны, следующий слайд. Мне бы хотелось поименно напомнить всех их. Это Николай Михайлович Амосов, Александр Николаевич Баков, мой учитель Александр Александрович Вишневский, Петр Андреевич Куприянов, основатель нашей специальности Евгений Николаевич Мишалкин, Петр Васильевич, Борис Васильевич Круглов, Петровский и Федор Григорьевич Углов. Вот они, кардиохирурги, все бывшие армейские фронтовые хирурги, в те сложные послевоенные годы начали нашу специальность. И наше дело все дальше продвигать и расширять ее возможности. Как показала жизнь, они безграничны. Вы знаете, мне бы хотелось закончить выступление кратко. Один из основателей философии итальянского возрождения, Ренессанса, кардинал-епископ Николай Кузанский выдвигал такую позицию. Каждое новое знание открывает пространство незнания, и оно постоянное и бесконечное. Поэтому наше развитие впереди все ждет нас. И отсюда, если я хотел вам напомнить, все, что помнит латынь, per aspera et astra. Успеха в нашем начинании. Спасибо большое.
Слово предоставляется председателю общества Осиеву Александру Григорьевичу.
Спасибо большое за предоставленную трибуну. Съезд — это всегда событие. 3,5 года назад был съезд, который мне доверили быть председателем. Я читаюсь завтра о проделанной работе. Сегодня же хочется после открытия съезда пожелать всем плодотворной работы, великолепные лекции, которые вы услышите на пленарных заседаниях. И в каждом из залов пройдут заседания по тематикам, где можно обменяться мнениями в кулуарах. И надеюсь на плодотворную работу. И спасибо всем тем, кто поддержал общество и приехал из всех регионов страны, от Дальнего Востока до Калининграда. И надеюсь, что все сложится, и это общество продолжит дальнейшую работу. Спасибо.
Слово предоставляется главному кардиохирургу Министерства здравоохранения России, нашему лидеру кардиохирургии, академику Бакеле Леону Анатольевичу. Пожалуйста.
Глубоко уважаемый Давид Георгиевич, президиум, глубоко уважаемые коллеги, для меня очень большая честь и радость сегодня сказать несколько слов в связи с началом работы съезда интервенционных кардиологов. Тем более, что я очень воодушевлен по дороге сюда, с работы, прочитал большое, огромное интервью на второй странице «Московского комсомольца», который выходит тиражом, как вы знаете, 11 миллионов штук. Очень советую вам тоже почитать. Там очень много сказано об истории, о, так скажем, достижениях и так далее. Действительно, мы в стране очень продвинулись в этом направлении. Очень большим и важным событием было создание сосудистых центров. Как ни странно, в том смысле, что, казалось бы, вот такая страна разнообразная, а центры, в общем-то, работают в рамках такой определенной программы. По крайней мере, куда бы мы ни приехали, сегодня есть возможность получить помощь в определенном объеме. Есть, конечно, вопросы, которые должны быть расчленены между кардиохирургами и интервенционными кардиологами, кардиохирургами. Хотел бы занять у вас 2-3 минуты, Давид Григорьевич, высказать свою точку зрения, чтобы было понятно наше отношение к этим вопросам. В частности, Значит, я не знаю, сколько здесь в зале находится аритмологов, но сложилось ложное впечатление о том, что интервенционным пособием можно устранить, там, скажем, длительную существующую форму фибрилляции предсердий, то, что называется мерцательной аритмией. Это требует отдельного объяснения, могу сказать, что это абсолютная чушь. Потому что, как говорит создатель операции МЕИС-3, Джим Какс, делаются 3, 4, 5 операций интервенционных, и дальше в левом предсердии ничего не остается, и говорят, нет мерцательной аритмии. На самом деле оно перестает просто сокращаться, замещается фиброзом и так далее. Есть, например, скажем, согласительные документы между серьезными организациями, когда надо делать, скажем, стентирование коронарных артерий, когда надо делать операцию. Мы знаем, что многососудистое поражение, ствол левой, главный ствол левой коронарной артерии, сопутствующий диабет, нужно делать, скажем, операцию. Конечно, ни в одной стране мира полностью этого никто не придерживается. Но я, как президент Ассоциации сердечно-сосудистых хирургов, хотел бы, чтобы у нас в стране была гармония. И надо помнить, с чего начиналась, скажем, операция замещения артального клапана. Алан Крибье, который был многократно нашим гостем, которого мы очень хорошо знаем, предложил ее для, скажем, больных, которые могли бы не перенести операцию с искусственным кровообращением. Дальше технологии развились. Но это не значит, что мы сегодня должны всем больным советовать замену артального клапана трансартериальным путем. Потому что я выезжал с моим очень близким другом единственный раз в жизни на такую операцию, потому что у него и стенты стояли, и то, и сё. И я поехал с ним в Англию. И когда он вышел после консультации, он сказал, ты знаешь, мне насчитали 135% летального исхода. Там 20% авиаблокады, значит, там это самая регургитация после операции, ну, много всего. Поэтому я надеюсь, что буду правильно понят, мы абсолютно настроены к сотрудничеству. Я бы вообще хотел сказать, особо отметить выдающуюся роль Давида Георгиевича Иоселиани, который был первым в Советском Союзе специалистом, который на базе 15-й городской больницы, где у нас были филиалы, потому что у нас не хватало тогда территории на Ленинском проспекте, первым специалистом, который начал эти операции делать систематически. И вот сегодня мы имеем центр, который он возглавляет, в котором делается весь арсенал операций, который сегодня существует в мировой практике. Поздравляю вас с началом. Еще раз хотел бы подчеркнуть, что мы абсолютно расположены к взаимодействию. Мы считаем, что hard team – это не пустые слова, это то, что должно лежать в основе. Но зачем нужны согласительные документы? В клинике у Иоселиани, в клинике у Бойцова и так далее вы можете иметь эту hard team, но, скажем, там в 100 километрах от Москвы у вас нет такой возможности иметь hard team. И тогда, для того, чтобы врач не попал под суд, он должен сказать, я пользовался вот этим документом. И, на мой взгляд, вчера вот у нас было совещание в Министерстве здравоохранения, создано, вы знаете, 21 национальный исследовательский центр, в том числе вот Бакулевский центр вошел туда. И там тема конфликта между врачом и пациентом возникла очень остро. Потому что сегодня ОМС защищает интересы пациента, а врач ничем не защищен. Эта тема во многих странах существовала в виде того, что врач, если вы приезжаете на международную конференцию, вы видите даже наших очень красивых мусульманок, которые сидят, все записывают, потому что согласительные документы – это то, что спасает от судебного иска. И поэтому мы особенно вот в Ассоциации сердечно-сосудистых хирургов придаем этому большое значение. Поздравляю вас. Извините, что я так долго говорил, но хотелось какие-то основные вещи вам сказать от своего имени. Спасибо большое.
Спасибо, Лев Анатольевич, спасибо большое. У нас еще одно приветствие. Я предоставляю слово профессору Шевченко, проректору первого университета, Московского медицинского университета имени Сеченова. Да. Да, я сказал, что Шевченко Сергей Борисович. Да, и, я еще должен для информации сообщить, что наш центр, которым я руковожу, сейчас слился, или не знаю, как это, соединился с Первым медицинским университетом, Первым Московским университетом, так что в дальнейшем, наверное, уже у нас будет объединенное усилие в развитии интервенционной кардиологии. Пожалуйста, Сергей Борисович.
Спасибо, Давид Георгиевич. Уважаемые члены сегодняшнего высокого собрания, съезда, посвященного интервенционной кардиологии. И этот 6-й съезд, наверное, имеет свои высокие позиции, которые, наверное, будут являться основой для дальнейшего развития вашей специальности. Но я прежде всего хотел поблагодарить за то, что есть такая возможность поприветствовать всех участников съезда от имени ректора нашего университета, Сеченовского университета, он теперь сейчас называется после ребрендинга, поскольку мы вошли в программу 5 и академик Российской академии наук Петр Витальевич Дудочка всех вас приветствует, желает вам плодотворной работы и просил меня лично пожелать вам успехов в сегодняшнем мероприятии. Конечно же, что такое съезд? Съезд – это серьезное мероприятие, которое подводит определенные итоги предыдущих лет, и 6 лет подряд вы проводите это мероприятие, и, наверное, оправданно. Казалось бы, съезд и каждый год. Но ваша специальность отличается, на мой взгляд, очень серьезными положительными качествами, которые нужно охарактеризовать следующим. Вы, наверное, являетесь самыми ведущими в развитии и быстром внедрении новейших технологий в практику клиническую. И, конечно, здесь без науки не обойтись, и научные достижения, которые вы имеете, требуют постоянного обсуждения и выработки каких-то определенных технологий в дальнейшем. Поскольку я являюсь проректором по науке и профессиональному образованию, я не могу об этом не сказать, поскольку вот эти достижения, которые существуют в науке, в том числе в вашей специальности, в первую очередь должно уже сейчас сразу же внедряться в профессиональную подготовку специалистов, которые работают у вас в вашей области. Почему? Потому что вот такая связка, она должна быть постоянной, на мой взгляд, и вот это как раз таки сюжет сегодняшнего дня, этот вызов, который мы должны тоже соединять в себе. Наверное, то, что вот Давид Георгиевич уже сказал, что его центр вошел в состав университета как клиническое подразделение. А если вы знаете, у нас в университете 3500 коек, многопрофильный стационар по всем практически направлениям, то для нас, конечно, развитие такого направления еще узкоспециализированного – это большой плюс и большое движение вперед, потому что как раз-таки вот эта связка между наукой, практикой и профессиональным образованием у нас получается в одном месте. И здесь, конечно, мы должны объединить усилия с коллективом Давида Георгиевича для того, чтобы двинуться вперед и чтобы центр являлся как бы одним из лидеров в развитии этих новых технологий. Те вызовы, которые существуют на вашей специальности, в том числе, они дают повод для того, чтобы требования, которые мы предъявляем и которые постоянно сейчас говорят специалистам, они все время будут увеличиваться. Тем более это совпадает с теми трендами, которые существуют сейчас в аккредитации специалистов. Как вы знаете, последние 2 года выпускники вузов, прежде чем иметь доступ к специальности, они проходят аккредитацию. Это новая форма, которая была внедрена Министерством здравоохранения, и она позволяет сейчас оценивать объективное знание выпускников после сдачи государственного аттестационного экзамена в виде 3-ступенчатого уровня оценки знаний. Это тестовый контроль, который включает в себя достаточно большое количество вопросов. Это объективный структурированный клинический экзамен на манекенах и собеседование с определенными членами комиссии. Я это вспомнил лишь почему, потому что с 2020 года все специалисты пойдут по этой схеме, и в том числе и вы, у тех, у которых заканчивается квалификационная категория, будут проходить через эту ступень оценки знаний. И вот наша задача, конечно, вот совмещать самые последние достижения, применять их в этих технологиях, которые позволят оценивать ваши знания. И вот в этой связи я хотел бы тоже обратить ваше внимание на то, чтобы эти вопросы не оставались в тени сегодняшнего вашего обсуждения на съезде. Это стратегические вопросы, которые, на мой взгляд, будут определять развитие вашей специальности вперед. Ну и, конечно же, хотел вам пожелать всем успехов в творчестве, хорошего здоровья и хорошего настроения. Спасибо.
Есть поздравления и приветствия из Министерства здравоохранения, есть из исполкома стран независимых государств. Я не знаю, может быть, вы просто огласите, не надо все читать, весь текст, чтобы не тянуть долго. А? Нет, это...
В наш адрес поступили приветствия от исполкома Содружества независимых государств, подписанные председателем исполкома Лебедевым, а также от Министерства здравоохранения за подписью заместителя министра Краевого, в которых в этом приветствии пожелают успеха нашему мероприятию и доброго здоровья всем участникам.
И, наконец, я хочу с большим удовольствием и с большой благодарностью предоставить слово выдающемуся кардиологу, выдающемуся интервенционному кардиологу Бернхарду Майеру из Швейцарии, который отложил все свои дела и приехал, чтобы представить вам лекцию о втором выдающемся человеке, который и начал все то, что мы продолжаем, а именно об Андреасе Грюнтциге, с которым довелось работать с Бернхард Майеру. И, ну, вот если можно так по хронологии, я насколько знаю, если я не так, я ошибаюсь, пусть меня поправят, что Бернхард Майер был вторым после Грюнтцига, который начал выполнять ангиопластию. Нет, и хватит его. Да, поэтому, я думаю, будет очень приятно всем послушать его мемориальную лекцию. Предоставляем слово.
Thank you, David Ioseliani. It's a great pleasure and honor for me to be back here in this beautiful city, this beautiful lecture room, to talk to you about the 40-year history, the ruby anniversary of coronary angioplasty. I'd also like to thank the Russian Society of Cardiology for the distinguished panel, and you as an audience, and Yelena Bogatyrenko, the right hand of David Ioseliani, who organized this meeting to perfection. We started a long time ago with invasive cardiology or interventions. In 1926, Stephen Hales was the first to measure invasively the blood pressure of a horse. You can see here that he just stuck the carotid artery and looked how high the blood was climbing, and of course he measured 241 centimeters, calculate that by the specific weight of blood and mercury, and you get a blood pressure in this horse of 186. Then of course we needed X-rays, and Wilhelm Conrad Röntgen, a German physicist, actually developed X-rays, and this is the first X-ray in the world. It's the hand of his wife. His mother-in-law probably was not at hand at that moment, so he took his wife for this experiment. The first angiography in a dead body's hand was quite brisk and quite good resolution, but of course this mixture that was used would be deadly in a living person. Then of course, and Dr. Valentka has already mentioned him, Werner Forssmann was the first to do a catheterization in a living human being, and that was his own body that he used with his self-experiment, putting a catheter down his right atrium. He proved that this was compatible with life. First, selective coronary angiography was also a prerequisite. Of course, doing repair inside the coronary arteries was done by Mason Soames, more or less inadvertently. He wanted to do an aortography, and then the catheter slipped into the right coronary artery, and so he got this quite crisp first coronary angiogram in 1958. And then we've already heard it, Andreas Grüntziga, a German physician working in Switzerland, was the one who developed a therapeutic intervention by catheter that became a world standard and the most common medical intervention of importance around the world today, 40 years later. Unfortunately, as you can see here, he died very young in an accident, and we can only surmise, what, looking at his face, what he would look like today at 78 years of age if he had lived on. What he did is he changed cardiology from a purely diagnostic discipline, where of course you know what's wrong with the patient, you can give some good advice, maybe some pills, but that is it, to a semi-surgical intervention. Just being diagnostic sometimes may have this reaction in the patient, and from Grüntzig on, of course, we could offer, like the surgeons, we could offer the patient some substantial repair, and not only good advice. This is the first catheterization laboratory where Grüntzig did his first procedure 40 years ago, and you can easily see that you could see nothing on fluoroscopy. There were no still frames, there was no replay at the time, so you can imagine that it was quite difficult to work in the coronary artery with just that much of visibility. And this is the first case. Let me just talk about the first case. The patient was also 38 years of age, like Grüntzig at the time, by coincidence, born in 39. And this was his proximal LAD stenosis that he had. This was done 2 days before the intervention by a radiologist. And then I was taking care of the patient at the time, so Grüntzig was not here on September 14th, but on September 15th I showed him this picture and said, this is probably the case you were looking for quite some time to start your procedure in coronary arteries. Grüntzig was already doing peripheral balloon angioplasty for quite a few years. And of course he thought that was exactly what he was looking for, so he went to the patient, got his informed consent just orally, and then 2 days later, this was the result after inflating his balloon. Then there was a follow-up a few weeks later that was agreed upon by the patient just to see if it was holding on, and sure and enough, it was still a good result. Exactly on the day, 10 years later, Andreas Grüntziga unfortunately already had died by that time. Spencer King in Atlanta did this further 10-year follow-up angiography showing a pristine look of this dilated stenosis. By the way, this was done with a 4-French catheter outpatient procedure already at the time in 1987. And then I was taking care of the patients ever since the first intervention, and 20 years after the intervention he called me and he said, look, I have similar symptoms that I had before Andreas Grüntzig did this first case on me, and why don't you have another look? So I had another look and I saw this lesion. It was not quite exactly the same region, but more or less, so I thought this is going to spoil the history if I do an angioplasty on this lesion in 2000. So I sent him home, said, this doesn't look significant, you better go home. But he called me again a few weeks later and told me, or 5 months later, I'm really not feeling good, I have the same symptoms, and Grüntzig took care of it 20 years ago, 23 years ago, why don't you do the same? So I did an FFR measurement in 2000 that was already available. I never do FFR measurements in my cases, and I'll let you know why a little later. But in this case, I thought this will get me out of ruining the history and having to redilate Gryuntzig's first angioplasty. And it was normal. FFR was normal, so I told him I don't need to do anything. FFR is normal. But he said, no, I'm not going away. I want you to treat it. So I caved in and I did a balloon angioplasty, and this is what it looked like. Quite okay, but there was a little dissection, so I told him we're finished, but he said, we are not finished, everybody gets a stent. I want the stent. It was in the year 2000, of course. So I put in a stent, and I had to admit it looked better after the stent. But then, only a few weeks later, like 2 months later, he called me and said, now I'm having symptoms much worse than I ever had before. And of course, he had pretty bad in-stent restenosis. So I redilated that just with a simple balloon, and this was the result. Now you can imagine that this first patient thought that we hadn't made any progress in 23 years, because the first time he was here, Gryuntzig took one look, put one balloon in, and he was good for 23 years. The second time he had to come twice, talked me into doing something, and when I did something it immediately relapsed, and he had to come a third time. So he said, you made no progress in 23 years, things have become a lot more complicated. But then the story goes on. He was good for another 14 years, and then 37 years after his initial angioplasty, he came back with symptoms again, and now he had this. You know, it's not really the initial lesion, which was a bit more distal, it's somewhere between my stent and the initial lesion. So of course we this time treated that with a drug-eluting stent, and ever since he has been okay again. So that's the story of the first patient. My role at the first intervention was a very small one. I have to be very humble. David exaggerated what I was doing, but I still can claim that I saved the first patient's life because I held his groin. If I had walked away there, he would have died. So I was a lifesaver for him. And this is now the first patient at his 40-year anniversary, which we celebrated in Zurich a couple of weeks ago, and you can see that he is still in excellent shape. Now he was born in 39, and his parents gave him the name Adolf. You can imagine that he was in for a hard life, because by the time he was 6 years old, the Second World War was over, and he was still called Adolf. In 1980, Gryuntzig did his last life course, you all know that is now very common, because he also introduced life courses to cardiology, and this was the last one he did in Zurich before he moved on to the United States. It was a remarkable one because he was here as the host, and then there was Charles Stoddard, who had been the first to do therapeutic intervention in peripheral arteries, American radiologist. There was also Mason Soames, who did coronary angiography as a first man, as we all know. By the way, also Gryuntzig's mother was here, standing next to me during that course. There was also Judkins. And Judkins was doing it from the leg, and Soames was doing it from the arm. We now have the same question again, should we do it from the leg or from the arm? At first it was only arm, then Judkins took it all over to the leg, and now we're kind of moving back. Now, certainly one of the strong features of Andreas Gryuntzig was that he believed in what he was doing, and that's my also recommendation to the young cardiologists here in the room. If you do something, you have to believe in what you're doing. And you see here that he had a cardiac catheterization, coronary angiogram the year before he died. Just he wanted to know his coronary arteries, and if he had needed angioplasty, he certainly would have had it absolutely free of stress at the end of this diagnostic angiography, which was normal. Not quite free of stress was the guy who did it, Hal Whitworth, who was the guy who did the angiogram. He had a little bit of stress during his past year. And here you see him, Andreas Gryuntzig, just a few hours later. He did his angiogram on the day of the Christmas dinner of the Atlanta hospital where he was working, and you see him just a few hours later leaving the hospital to go for the dinner. So outpatient angiography, even going through the groin, was of course quite possible already 20 or 30 years ago. Now we all know that the PCI or PPCA, as it was called in the beginning, had a pretty slow start. It was not accepted right away, but now it has become very common. Then in the 86, the Americans introduced atherectomy, laser treatment. The Europeans introduced stent treatment, and you can see that certainly the stent prevailed while atherectomy kind of disappeared, except for a rare rotablation that even can help today. And then, of course, there was brachytherapy to prevent restenosis, but it was too complicated. You had to irradiate 10 lesions to prevent one restenosis. That was not practical. And, of course, the drug-eluting stent was a much easier way to combat restenosis. And we all know that the biovascular scaffold was already introduced shortly after the first stent in Japan, but it never made really any or met any attention until the absorbed stent, but we all know that this already is fading out also. We're not sure if the absorbable scaffold will come back. I never used the absorb in our center, which was an exception. Most people liked it, but I never liked it because I said we're already quite happy as Dr. Cass here on this island with the modern drug-eluting stents, which is very pretty and very good looking and actually all we need. So we don't need to be rescued by this boat called Absorb. So you see here Dr. Cass is kind of hiding. He doesn't want to be rescued. So far, of course, really this ship was not rescuing anybody. So to sum up, what we've seen in the 40 years is it's certainly still the balloon up there reigning supremely. And of course now it's crowned since 1986 by the crown called stent, and the stent now is active, it's sweating out some medication. All the other things, are nice to have, but not really that important, except maybe in rare cases the rotablator and ECMO can save a life when you have a crash in the catheterization laboratory. But all the rest you can do without. Now just a few words about two things that are quite trendy and modern, but I have my reservations about. One is the radial approach. In the late 80s, Ferdinand Quimenet, you see him here in young years, and that's what he looks nowadays, sent me this picture, and he said, actually sent it in 92, but he already had been doing this for a few years. Why don't you do your PCIs through the radial artery? I'm doing them, and you see I'm here on the marketplace of Amsterdam. One has just had it, one is having it, and the others are queuing up for it. It's a very simple procedure. And of course, I like simple procedures, so I tried it out. Particularly nice, of course, is the patient can get up right after the procedure and walk out of the room and go to the bathroom if he wants to. But then I found out that it was actually much more complicated. You needed all these additional paraphernalia for the radial approach. For the femoral approach, all you needed was a needle and a standard wire. So it kind of felt to me like being able to ride a bicycle, which is a femoral approach, and now somebody wants me to ride a monocycle. That's the radial approach. So of course you can bring out pizza on a monocycle if you're trained to ride the monocycle, and everybody can train that. But it's much easier to deliver pizza on a bicycle, and particularly when the terrain gets difficult. The bicycle has a lot of advantages over the monocycle. And so the learning curve is much longer with the monocycle than with the bicycle. So why should everybody have to ride a monocycle if we have bicycles that everybody learns much easier? If everybody rides a monocycle, of course, the longer learning curve and all the crashes are his own problems. But with radial rather than femoral angiography and angioplasty, it's actually the patient who pays for the longer learning curve of all the young interventionalists who have to learn to ride the monocycle rather than the bicycle. And of course, that all kind of became popular because of the Matrix trial, which showed a survival or at least a hard endpoint benefit. But when you look at the data more precisely, you can see that indeed it was only in the high radial centers. So all the centers who already did radials as a routine procedure, they had some advantage. But all the centers who did only occasional radial or very rarely radial, they had no advantage going radial over femoral. So if you're not already radial, you really don't have to get radial. Of course, if you already are more skilled riding the monocycle than the bicycle, you may well stay with your monocycle. And you can see that the bleeding problem that was highlighted by the matrix study actually doesn't show up if the focus is not on radial or femoral. This focus was on how you use the anticoagulation in PCI. And you see there was no difference in bleeding in femoral and radial, because as often in medicine, when you focus on something else, a difference that you highlight when you want to propagate something all of a sudden is no longer apparent. In addition, of course, there is the risk of radial occlusion, and you can see in all these series looking at radial occlusion, it goes up to 35%, which I think is exaggerated. Some have no occlusions, but most of them have some percentage between 5 and 15% of radial occlusions, and it is not worth sacrificing a radial artery for just a diagnostic study or for a PCI. And of course, the larger the catheter you squeeze through the radial artery, the more likely it's going to be occluded. With 7 French catheter, which is actually on the outside a 9 French. If you use the 7 French sheet, the outside is 9 French. So you have 20% occlusion with 5 French catheter, which on the outside of the sheet is 7 French. You have 5%, so you should really go small, and you should leave away the sheet. This is where if I go radial, I just go in directly with a 5 French AL2 catheter, with which I can do my whole procedure. I can do the right coronary artery, I can dilate these lesions on the left coronary artery with the same catheter and see the results, and I can do the left ventriculogram with just one catheter, no need for exchanging. And then, of course, there's the question of radiation. For the patient, there's not much difference, 10% more radiation in the radial case, but for the operator, the difference is considerable. It's almost doubling your stray radiation that you're getting. And this is really not worth it, because if you do your whole career doing radials, you get twice as much radiation than if you do it femoral, and what you get femoral is already quite a lot. So talk to your family. I'm sure they will want you not to do too many radial cases. The other thing I'd like to take issue here with is FFR. I call this the FFR fallacy. As I said before, I never use FFR in my clinical cases. I use it for research because it shows quite nicely whether the stenosis is significant or not. But that's not the question. The question is, will this stenosis have an occlusion soon? And of course, higher stenosis have a higher likelihood of having an occlusion soon, but even low-grade stenosis have some potential of having an occlusion. And this occlusion can be prevented by intervention. Now, you all know the FAME2 trial actually was set to show that you should do FFR, and then you should dilate if FFR is not normal. Here you see if you dilate, you have a follow-up with 8% problems. If FFR is not normal and you don't dilate, you have twice as many problems. Most of them were that the patient came back to have the lesion treated, that you didn't treat because it was randomized out of treatment. Now they showed this on the background of those with a normal FFR, where they said we did nothing because FFR is normal, and you see that our treated patients with that normal FFR had the same outcome as those with normal FFR. But they cheated this group of patients who also had 9% of events here in follow-up out of the chance of also about halving their events. If they had done PCI on those patients too, which I would have done, they would probably only have had 4% of problems. So not doing a lesion because the FFR is normal, in my opinion, is not a good idea. And you all know there has been a trial out there which has not been published yet because it's still during follow-up, but it was stopped prematurely by the safety monitoring committee because the mortality was actually significantly, it was more than doubled if they were not dilating the lesions that had a normal FFR. If they dilated all the lesions, even though they're the normal FFR, they had only half the mortality during the first year than if they did not, which is actually understandable. Now, once this trial is published, FFR will, of course, have a hard time to persist. Now, of course, between the surgical or the medical treatment, and Dr. Bakheria will excuse me for this. Of course, the patient, if you ask the patient, will always, opt for the catheter-based treatment, because the day he will think, what will I be like the day after the intervention? Now, after surgery, this is here. After a catheter intervention, it looks like this. Both patients are semi-comatose. I have to admit that. Both need the attention of some female person close by. Both have some dressing here, and both need some fluid to maintain their circulation. But you see, it's really not the same, and the patient will go for the left side. So we really have to, tell the surgeons we are in this boat together, and you can see that we really are, just not rowing in the same direction. So just to sum up this at the end, coronary angioplasty is a great thing to have, but we should use it in a logical fashion. So I call this metaphorical depiction of life, the course of life, or if you blank out the O, it's the curse of life. When we are born, with coronary artery disease, we can show that nicely. We are cast on this plane, and we want to arrive here at the very end. Someday we will fall off the cliff for sure, but the later the better. Now with coronary artery disease, like our first PCI patient, of course we get close to the cliff. But and then we may get stable with drugs, but I still think we should come back with PCI to the safe middle line, and then, with luck, get off to the very end, or maybe have another intervention a bit later on. Now, if again, you're stable here with the first coronary artery disease, and now if you look to the FFR trials or the COURAGE trial comparing medical therapy to PCI, they say you shouldn't do PCI here because the patient is alive and is stable. Same thing here, you're alive and stable, there is no difference. But there is a difference if you're out here or if you're here, because even in the best of cases, this is your course. And if you have another lesion, of course, that's not the way to go. So you should not listen to those trials, COURAGE and FAME, and do the lesions when you see them. And the surgeons have been able to prove that they're saving lives. It should not only be about saving lives, because most doctors just work for quality of life, not for quantity of life. But since we, the cardiologists and the cardiac surgeons, work in the heart, we are thought to should be able to prove that we are prolonging life. The surgeons did that very early on with the CAST trial, working on triple vascular disease, left main stem. They were saving lives with revascularization. With the balloon angioplasty of Andreasa Grüntziga before the stents, we were pretty close of doing it, we just didn't quite make it significantly. And then it got worse because the stents were introduced and they had late thrombosis. Balloon angioplasty never had a late occlusion. It had acute problems, but never had a late occlusion. Whereas stents, of course, brought in the mortality with late stent thrombosis. And the first drug-eluting stents were actually not better. They were even thought to be worse than the bare metal stents. They were not worse, but they were not better. They still had those late thrombotic risk. And only now that the last generation of drug-eluting stents is so good that we actually now can prove that we even prolong life. We not only improve quality of life, we prolong it. So let's just finish with some of the spin-offs of coronary angioplasty. First of all, you can see that coronary intervention was actually already started in 1972 in Brazil with a first via recanalization of a coronary artery. But that was not published outside of Brazil, and nobody knew about it. It was really Gryuntsiga who had all the heads turned when he started coronary angioplasty as an elective procedure. And the only really important additional coronary intervention was the stent implantation, first done in France by Jacques Well in 1986. And then atherectomy, as I said, came in but also went out again. Brachytherapy went in and went out again, came in and went out again. But of course we had the spin-offs. We had, of course, electrophysiology is kind of a spin-off of coronary interventions, and that's a very, very large, important part. But certainly, we should also know that already valve procedures had been done in 1953, but of course in a rare indication, so again no heads were turned. Closure of atrial septal defects, which is the same as a PFO closure, was actually preceding coronary angioplasty, but again didn't catch a lot of attention because it was in the hands of pediatric cardiologists in the beginning. And then, of course, and we already heard about it, Alain Tribier brought in aortic valve replacement, and that's the most important spin-off of coronary angioplasty so far. Of course, once we have a good mitral valve that we can implant, this will become almost as important as aortic valve replacement. We're not quite there yet, although we're 5 years out of the first implantation. And of course, left atrial appendage closure is also something I will quickly touch upon. Now we're also celebrating the 20th anniversary of the first dedicated PFO closure device put in. I had the pleasure to do that in Switzerland with Kurt Amplatz, the inventor, coming over for his first case on September 10, 1997. And for 20 years I've been on a mission to make PFO closure more popular. It's a very rough and uphill road, I can tell you. To provoke people, I usually show this slide. I say all PFO should be closed, and we can include also ASDs. All ASDs and PFO should be closed because we have this very elegant method called Amplatzer devices or other devices that were derived from it. Here just one picture showing an ASD in three-dimensional echocardiography seen from left and from right. This is about 10 years old, but it's still a very nice depiction of how you can show that, and this is a few months after closing it with an Amplatzer device. You see how nice this result looks, and it may take as little as 15 minutes to do such a case. And just to finish the ASDs, I think that all large ASDs need to be closed. Even the surgeons agree to that because they will close them surgically if we cannot close them by catheter because they are large. But also all the small ASDs should be closed because they are small. Because it's so easy to close that there are no complications, 100% success to close a small ASD. It's an outpatient procedure. The patient spends a few hours at the hospital, and the same day he or she can go back to doing sports. It's such an easy intervention. Now the PFO is just one picture that may be quite impressive. You know, the Mayo Clinic United States, they looked at the prevalence of a patent foramen ovale in people dying, 1,000 autopsies they looked at young age or at old age, and they saw that the prevalence was decreasing. Now they said this proves that the PFO is closing throughout life. This is about as likely as your mouth closing because you don't talk for a day or two. It's very unlikely to happen. The only other explanation for this, there is a selective mortality. If you have a PFO, you're less likely to get old than if you don't have a PFO. And just showing that the PFO really is a killer at times, fortunately rarely, but it is a killer. Look at this 34-year-old man. He was playing soccer, completely healthy, one afternoon with his colleagues. He got a bruise to his thigh because of a guy, ever ran into him, and went home, went to sleep, went to work the next morning and dropped dead at work, was resuscitated by his colleagues, and came into the hospital with this ECG showing a huge myocardial infarction. We put him on an artificial heart, but we had to stop the artificial heart because his brain was dead due to lay resuscitation, which hadn't been enough. And you can see that he had a huge infarction at autopsy. The entire left main circulation, only the right coronary artery was still perfusing. And we did find the left main occlusion, of course, at coronary angiography when we had put in the artificial heart. And this was the reason. You can see that there was some thrombosis in the vein where he had his bruise the day before. And of course, the reason for dying was the PFO, because part of the clot was found in the pulmonary arteries, but it was so small that you wouldn't even have noticed having a small pulmonary embolism. But a small clot or a fairly small clot passed through the PFO, went to the left main and killed this young man. And this had actually been shown also like 1998, that's 20 years ago, by a German group who showed that people come in with pulmonary embolism, proving that they had venous thrombosis and parts of the clot traveling past the PFO. that the question whether or not the people had a PFO was very instrumental. Mortality was more than double just by the fact that the PFO was there, and of course this was due to simultaneous stroke, because part of the clot didn't go to the pulmonary artery but to the brain, and some also myocardial infarctions, like the patient I just showed you. If the clot goes to the left main, it will also kill you. That's a lot rarer than to the brain. And you know, like 7 or 8 years later, this was actually 10 years later, this was published in The Lancet. It is unbelievable, you know, that in this series of Danish population, where they looked at people who came in with a pulmonary embolism and saw that simultaneously they had a high risk of having myocardial infarction or stroke, but did not mention the PFO in a single word. They just forgot about the PFO. They wondered why that would be, came up with no explanation. That's the PFO in almost all of these cases. Another proof of this deadly potential of the PFO. We did a long-term study, not randomized patients, but quite so to speak randomized, because our neurologist in the 90s sent some people for PFO closure and some they kept for oral anticoagulation or aspirin. They didn't have a clue whom to send and whom not to send. They compared 150 patients whom they had sent for closure with 150 patients whom they had not sent. And a 10-year follow-up in the hands of the neurologist showed that the yearly mortality was 0.4% if they had sent it to PFO closure, and it was significantly higher, 3 times as high, if they had not sent the patient for closure, showing that PFO closure actually saves lives. Of course, we have the truly randomized trials, and we all know that we now have 5 of them. So 2 of them are so-called negative, 3 of them are positive, but even the negative ones, of course, are positive. They just didn't quite make significance. Like here, you see that significance just was missed. It was going all the right way to the left, closure being better than medical therapy. And of course, if you look, what is the alternative? If you just give aspirin, that's not an alternative. That's significantly worse than PFO closure. If you give oral anticoagulation, it is equal. But even that means that PFO closure is not worse than oral anticoagulation. And if you have the choice between lifelong oral anticoagulation and a 15-minute intervention with no risk, you will certainly go for the intervention. So every patient should be at least offered PFO closure. Now, of course, we have the full 5 trials, and you see overall these trials show a significant improvement of preventing strokes with PFO closure rather than medical therapy. Some of them had not been quite significant, but they were all going to the same direction. And now, of course, people say, well, that's not quite innocuous because you get atrial fibrillation. And really, that's true. The randomized trials have a higher propensity of atrial fibrillation. But this atrial fibrillation was almost always early after the implantation and then went away. So it's not the atrial fibrillation in the old person that we are talking about, where you have to use oral anticoagulation and get all the bleeding problems. And actually, there are some trials, not randomized, but comparative trials, quite a lot of them, who looked at the prevalence of atrial fibrillation pre and post in the same patient in a serial way. And you can see that actually PFO closure, if anything, reduced in a person who had already had atrial fibrillation, the recurrence rate of atrial fibrillation compared to not closing the PFO, something I don't quite understand. But it doesn't seem overall atrial fibrillation is not something that should deter you from closing PFO. Now, looking at these randomized trials, you know, number needed to treat, if you only look for 1 year, is 200 PFO closures to prevent 1 stroke. That's just 1 year of follow-up. If you go for longer follow-up, this number decreases. So if you go for a 50 years of follow-up, a person 30 years of age, where you decide whether or not to close the PFO, may have 50 years of life expectancy. You only need to close 2 PFOs to prevent 1 stroke. And this is why this picture came about here. My children, I always told them you need to know if you have a PFO, but they were not interested in having a check until one of their friends, who was a neurology fellow, was in a randomized trial with migraine, and he was found to have a PFO. I told this guy who was often visiting our family, you should have your PFO closed because your migraine might get better and you will not have a stroke later on. But of course, his neurology colleagues told him, don't do that, the cardiologist just wants to do some intervention, don't do it. And then 5 years later, this poor guy had a bad stroke, could not talk any longer, was paralyzed, hemiplegic, and my children saw him and they were impressed and they came home and said, I want to know if I have a PFO, and if I have one, I want it closed. So I checked 10 of them with their friends, and by coincidence it was a couple who did have a big PFO looked for by TTE only. And of course, the same afternoon I closed the 2 PFOs. They spent like 3 hours at the hospital with diagnosis and treatment, and this shows then the next day. And I'm really glad that in our family there are no longer any open PFOs. And just one slide about migraine. You see again how you should interpret medical trials with caution. Now, we did a migraine trial, and it is called a negative trial again. What was our primary endpoint? And I selected that one afternoon, just having like 6 or 7 different endpoints that I could select. I said, we take this one as primary endpoint, so we took reduction in migraine days. We had a reduction from 2.9 to 1.7, but that didn't make the statistical significance. So our trial goes into the literature as a negative trial. It was not negative. An American trial with a little more patients did not select this as a primary endpoint, but it was a secondary endpoint in their trial. And it was significant in their trial, reduced from 3.4 to 2.0 because they had more patients. So it was significant in their trial. On the other hand, they had selected a primary endpoint as a responder rate of 50%, and they had a responder rate higher with PFO closure than without closure, but it just quite didn't make the significance. Whereas in our trial, this had been a secondary endpoint and it made the significance. So they go down as 2 negative trials, but if they had reversed their primary endpoints, it would have been easily possible they would be 2 positive trials. So please study your literature with this in mind. Now, just to show you the entire intervention cardiology procedure gamut, you can see that it goes from very easy and without complications to quite difficult and complication prone. And we have therapeutical trials like PCI, which may go from easy to complex, but it's a therapeutic trial, we accept that. We have other therapeutic interventions like ASD closure, TAVI, but then we have 2 preventive closures, PFO closure and LA closure. Now, PFO closure is the easiest thing we can do, so I think it's even easy to sell a preventive intervention if it has no complications, so to speak. It's a bit more difficult to sell a preventive intervention. It's not a therapeutic intervention, it's just done to, like a mechanical vaccination, to prevent something that might never happen, like bleeding or stroke. This is much more difficult to sell, but we all know it's now also on the way in. It has been done the first time 16 years ago by an interventional, by an electrophysiologist together with an interventional cardiologist with this device that is no longer available because it is clear that 90% of the clots in atrial fibrillation come from the left atrial appendage. So if you exclude that, there is no more any need for anticoagulation. We introduced a year later a very simple technique without echocardiographic guidance. Again, like a corneangiogram can be done in 20 minutes. Patient is awake and can walk out of the lab because it's a venous puncture and can go home the same day using a different device, an MPLATS device. The surgeon had already proved actually that closing the left atrial appendage during surgery as an additional procedure is actually reducing all-cause mortality during a follow-up of only 1 year. And now with the device, it is the Watchman device, it is proved it takes a bit longer, it takes 5 years to show a mortality benefit, closing that compared to vitamin K antagonism. Why does it take longer? Because at the beginning you have the complication of this preventive catheter-based procedure. And with our technique, shown in 1,000 patients by TCAS with the MPLATS technique, you see we are following the line of the Watchman cases, so it's probably a question of the principle of therapy rather than a question of the device use. Now you may say we're now using NOx, no longer vitamin K antagonists. NOx are better in preventing systemic embolism and stroke than warfarin, but if you put our MPLATS device series again on this curve, you see we're going along the NOAC line. in preventing stroke, and at the other side of the medal, of course, the bleeding side, we're doing much better, because even the NOACs, they're good drugs, better than more vitamin K antagonists, but they still have a bleeding rate of 2 to 4% per year. Whereas with LA closure, of course, you don't need to use oral anticoagulation in most patients, not even aspirin in some patients. This bleeding rate is significantly lower. And finally, a valve procedure. And again, Hokeria may excuse me for kind of talking in favor of closing the valve percutaneously nowadays and no longer surgically. We first had to prove, in very high-risk patients who could not be operated upon, that TAVR was as good or better, and it was better, the mortality was significantly decreased compared to just medical therapy. So in a way we had proved, now having the new shoes called TAVR, before we had the SAVR shoes, that with these new shoes we could conquer Mount Everest. Those inoperable patients were like Mount Everest. With these shoes you couldn't have even tried to go up there. But with our new hiking shoes we went up there several times and proved it. Now we do not have to do other randomized trials to prove that with these shoes we can also walk up a hill. Of course we can do that. That's self-understood. Nevertheless, of course, this trial was done with low-risk patients. You see again, compared this time to surgery, actually a lower mortality with TAVR than with surgical intervention. So I don't think we needed to do this trial, but it was done, and some more trials with low-risk patients are on the way. I don't think they should be on the way, because for me this is a clear thing, but they are on the way. And the durability of the valve, at least up to 5 years, is the same. And you see that you even get a little better valve, you get a larger surface because the valve ring is smaller. To put it through the catheter, of course, the engineers had to make the valve ring smaller than a surgical valve which is introduced openly. So you get a better valve with at least probably the same durability. If they're the same at 5 years, they will also be the same at 10 years, in my opinion. So my last slide is this one, Of course, surgeons can do combined procedures, that's their strong suit, and I think they should still, all the complex patients we can faithfully send to the surgical colleagues. They are doing a great job. Even complex coronary artery disease, in my opinion, should not have 3 or 4 stepwise catheter interventions, but one bypass surgery is much better, and that's what I would have if I had complex triple vessel disease. But we can also combine procedures. This is a one-stop shop procedure in an 88-year-old man who had a circumflex stenosis, an aortic stenosis. He had atrial flutter with bladder bleeding. So at the same intervention, he got a new valve, he got an LAE occluder, and of course he got his circumflex artery was fixed. And he only spent 1 night at the hospital. That is certainly something surgeons cannot match. Thank you very much.
Thank you, Bernie, for a very interesting and helpful lecture. Может быть, какие-то вопросы? No question. Thank you very much. Thank you. Тогда разрешите на этом завершить заседание и до 12:15.